So an acronym that we're using in the tactical setting, instead of like the ABC and now they changed it to CAB, is a March. So March assessment, and we'll go through a lot of it, is more of what we're teaching in TECC, what they teach in the tactical EMS world, and March. I didn't know if we had something to write on, but I'll just talk out loud. So March is going to be M is like massive hemorrhaging. Mm-hmm. So massive hemorrhaging is on any of the extremities, your arms, legs, something that you can use a tourniquet on. So that's why we give you guys a tourniquet. A is airway. So you're checking to see if the airway is patent. If it's not patent or not breathing, you're doing simple airway maneuvers like a head tilt, chin lift, jaw thrust. We're not really in this situation. If you're in the hot zone, you're not really doing C-spine immobilization. You're just making sure the person can breathe.
Sure.
R is respirations. So you're seeing if the person's breathing. You can check equal chest rise and fall. You can put your hands on their chest. You could rake, which is like you're using your fingertips to touch the thorax to make sure there is no gunshot wounds. That's when you would put in like a chest seal, a needle decompression if you're seeing equal chest rise and fall. Roll them over, check their back. If there's an entrance wound, there could be an exit wound for a gunshot wound. C is circulation. So you can double check your hemorrhaging. You can check a pulse if they have a radial pulse, carotid pulse, things like that, just to make sure that you're covering any of the other bleeds, any other things that can cause them to be in hypovolemic shock. And then H is like head hypothermia. Head, make sure there's no head injuries, no orbital blowout fractures, no injury to the back of the head. You can check their eyes if you can real quick. Jaw injuries, teeth injuries. A lot of people, if they get shot in the face, there's more of like a mouth injury or some teeth missing. And hypothermia. So a lot of these guys that are doing the March assessment, a lot of them kind of forget, like, if the patient's laying on the floor, your body's convecting all that heat because you're laying on the floor. So you want to try to make sure that the body is not on the floor as much. Either some people carry those the 99-cent space blankets that you see, or if they're talking, you can sit them up, like get most of the body off the floor, or put them in a chair, or put them like on something else that they're not going to convect, because hypothermia can it can decrease the clotting factors in your body, and you can eventually die from it.
Especially if they're low priority, and they're going to wait for.
And we
even moving people off of tile onto carpet would be enough to warm them to some degree.
And then the last thing, some people teach it, some people don't, is the E, like March E, and that's everything else. Like if you're getting out of the cold, I know it sounds crazy.
Cool.
If you're getting out of the cold zone, you can do pain medicine or splinting, things like that. You're not going to splint in like a warm or hot zone. You're not going to really carry about that stuff. And just making sure that they're out of harm's way before you start getting into more of the technical things. But with the IFACs that were provided, like we talked about, CAT tourniquet, wound packing, pressure dressing, shears, just regular compressed gauze, just to have for these police officers and first responders to have on them to handle a march.
So some of the big things to always think about, if we're putting on a tourniquet, we want to really make sure that we tighten it, take all the slack out of it, tighten it as much as you can before you try turning the windlass, because the windlass can only take out so much slack. So really try to make it as tight as possible.
And the windlass is the rod that you actually are twisting down. Right.
Exactly. And then using a second tourniquet, if more on the lower extremities, tends to be more than the upper extremities, but if one tourniquet is not doing the job, put a second one on. And then the other big thing to watch for is making sure that you're above the wound. There's often, if it's a penetrating injury, there may be a second wound, an exit wound, that is higher up that you may not see in the back of the leg or the back of the thigh.
Are you suggesting all bullets don't travel directly through the body in a linear fashion?
Yes, sometimes they do not.
Oh, okay.
So, that's one of the things to always think about with tourniquets. With needle decompression, there's been a kind of a shift in needle decompression. We have historically talked about second intercostal space, midclavicular line. Yep. There's been more of a push with TECC and some of the other trauma organizations out there to use more of a lateral approach. So fourth to fifth intercostal space, the mid to anterior axillary line, so not quite the middle of the body, but a little bit anterior to that, and using that as a position. That's helpful in in tactical EMS, because that's, with people with vests and other tactical gear on, you may have access to that area and not have access to the front. There's also, TECC goes through the kind of the mistakes that have been made in the past, but also the fact that as we get bigger as a society, the needles may not reach if you've gotten sort of more fat in that area.
Right.
And they think that in the lateral areas you have more access to the thorax with the normal size needle, and making sure you have the correct size needles as well. It's got to be.
So I can just take any old IV catheter out of my kit and just start darting people with it, right?
I mean, if
We're
it's
not using these 20s. These little guys.
so obviously large bore, right?
So they got to be big. I mean, and that's why we put these decompression needles in there, specific ones.
I mean, yeah, you can
The
definitely
study
tell
shows
a huge
they at
difference.
least have to be 3¼ inches long or longer.
I remember when I went to paramedic school 25 years ago. Then the discussion was 2 inches isn't making the thorax. I remember it was the medical examiner in Toledo was looking at all the decompressions the fire department, local jurisdictions had done, and how many of those weren't making the thorax. So you really need, pardon the pun, but you need a spear here.
Yeah.
Okay? Even small guy like myself, you still need the spear.
Yeah.
It's you're
For
not
sure.
sizing this to the individual.
Yeah.
Right.
I don't know if the camera can see, but there's a huge difference in an IV needle and what we're carrying. And actually, there's new ones coming out from North American Rescue that are actually a little bit longer and way wider to go through the like Dr. Dare said, to penetrate the bigger guys out there or bigger women out there to make sure.
No.
Oh,
No.
yes, it's hiding out here.
So yeah, just a little bit of visual representation of it.
Likewise, this is purpose made for said
Needle decompression.
for said procedure.
Yes.
It's actually lacking things that are regular. I mean, I can buy a 14 gauge 3¼ IV catheter, but what's
the difference?
The difference
Oh,
is
yeah.
the difference is simply that an IV catheter comes with that cap. So if you're on a budget and somebody gives you a whole bunch of 14 3¼ understand if you're darting a chest with that, you got to pull that cap off the back where this is already
And the material for the needle decompression is a little bit more thicker here too.
Oh, agreed. Yeah.
Yeah. I mean,
It's
that's
fun.
way thicker.
It's purpose made.
Yeah.
We're not pressing something into
No.
service that was.
Some of the old school ways, the guys were carrying like the 14s. I remember when we were carrying a few, and they were using the toothbrush holder because they were so big. Yeah,
We got a 6-inch. We had a 6-inch long catheter.
Yeah, and we're using toothbrush holders.
Toothbrush
Yeah,
holder,
that's how we carried them. But then, I mean, this is more practical. You can throw this in a kit and.
All right, personal curiosity. We're not there yet, and this is really for you, Dr. Dare.
Yeah.
Surgical thoracostomy, finger thoracostomy. Other states are allowing it.
I was going to say they are now in the scope of practice in other states.
In other states, right? I understand that there is at least a pathway to where we may get, hopefully soon,
Yes.
before I retire, the ability for you all as medical directors to have some broadening and allow for extra training kind of beyond what the state mandates. Is that a game changer, or are we just going to stick with needle thoracostomy?
I mean, I think that there's always going to be a place for needle thoracostomy. I mean, when you want to get something quick and decompress a chest, for sure you're going to start there. But then, and I mean, there's just like you're alluding to, we have over time expanded the role of EMS, pre-hospital care in general, right? I mean, everything that has gotten pushed down through that has become important and become pushed down ends up getting pushed out to the pre-hospital setting, right?
Mm-hmm.
12 lead
Within time,
EKGs.
yeah.
12 lead EKGs.
I was never trained in 12 lead EKGs as a
Heparin Brilinta, right? I mean,
perfect.
Oh, yeah.
Heparin Brilinta is now pushed out. Stroke care has gotten pushed out, getting early Mandan or
Van.
getting Van and Cincinnati's done ahead of time, and activating stroke alerts and STEMIs, TXA. I mean, all of those things that we never did in the pre-hospital setting before is getting pushed out into the pre-hospital setting. So do I think that something more, finger thoracostomy, even tube thoracostomies, will be coming to the pre-hospital environment? Yes, I think it will come to the
That
pre-hospital
seems the path that we're heading.
for sure. But I think there's always going to be a place for needle decompression.
And if you think about like what we talked about with TCCC in the military, we're about 3 or 4 years behind to what they're doing. Like they're probably doing it already. A lot of this stuff is coming to us.
Well, like Scott was saying, other states have even broadened the scope of practice.
I went out east and did a tactical medical practitioner course, and I was doing tube thoracostomies on the what we're doing with the hands-on. Sure. Obviously, we know I'm not doing it here, but yeah, like you said, it's already out there, and it's the flight medics are doing it, doctors are doing it. It all depends on where your hospital wants you to do and what's not, but it's out there already.
And the advantage there being it's durable, right? Because I mean, we put a needle in somebody's chest. We train on this. Hopefully, this is not new news to everybody.
Yeah.
It's rarely one and done,
Yeah.
right? Is that thing's going to occlude? It's going to kink
Yeah.
off. It's and keep throwing darts if that's the case.
Mm-hmm.
Right? So, but yeah, I mean, if let's just say we go the route of the finger thoracostomy, if again their blood pressure begins to deteriorate, if they're hard to bag or whatever, you can just stick your finger back up in there and
Yeah.
essentially burp them, right?
Right.
So, so that was the decompress. You made a very specific, and I think it requires reiteration because I don't know that we've hit this quite enough because I certainly was trained mid-axillary, right? But you were very specific. It's anterior axillary, and what's the difference and why is it important?
So you don't want to be so low that you end up hitting posterior structures, but also just based on gravity, things are going to be lower down.
Yeah.
So you want to be a little bit anterior so that you make sure you get into the air pocket, which is really what you're going for, and you want to obviously evacuate the tension or the pneumothorax. So it's very important to be.
And we're assuming most of these patients are supine, right?
Yeah,
So
right.
I mean,
Yeah,
it's
absolutely, for sure.
absolutely it just makes sense from a physics standpoint, right?
Right.
It's not not any crazy science here.
Yeah.
We talked about the decompression. We talked about some of the pitfalls of the the tourniquet is really just. You got to get them on tight. If you're turning that windlass 5, 6, 7 times, you didn't snug it down enough, right?
Mm-hmm.
It's something I even stress to new hires in my shop is they come in and do orientations. Like you got to put a boot on their chest and pull. So be it, right? I mean, it's going to hurt them. I think is the other thing that needs to be said.
Take it out of the package too. That's like one of our pet peeves.
Yeah,
when we
sure.
teach. I know it sounds really small or just mundane, but a lot of times we show up to teach and it's like, oh, what do you have? And it's in that cellophane wrapped package, and it's like, okay, so put a pair of gloves on, and then what are we going to do first? I'm going to try to do direct pressure, and then now try to open that.
Grab that with bloody hands.
Yeah, not going to happen. Open it. It's not going to go bad. Just get it out of the plastic, get it prepared to be able to be placed on someone's another pet peeve of mine.
100%, yeah.
And if you use one repeatedly for training, don't use that to be one to save a life.
So
very good point.
What now? I was with an individual who had some tactical training through the military.
Was it Joe?
Yeah, it was not Joe.
Me?
And
military dude. No.
Not that many years ago, but this person was really advocating that, in transport. So we're out of the, we're beyond the cold zone here. We're transporting to the hospital. Tourniquet's already. That we should be taking the time to convert patients that were tourniqueted to pressure dressings.
No.
Current thoughts on that? I mean, it's simply no, right? Is it worth it? Is it worth the time? Are we saving cells? Are we preventing rhabdomyolysis? I mean,
So the big push or the knock, maybe I should say, the big knock against tourniquets back in the day was, if you put a tourniquet on somebody, their limb is going to be ischemic and it's got to be cut off. There's no way that limb is going to come back. And in reality, ischemia, as we know, with STEMIs, strokes, everything else, you have 4 to 6 hours of ischemia before you have any kind of permanent damage. Again, in Northeast Ohio, nobody should be 4 to 6 hours away from anything.
We are flush with trauma centers.
So there's no reason to take a tourniquet down. Now, again, if military, you're in Afghanistan, you're talking about 2-day transport.
Hours, right?
Okay,
That's
sure.
different,
Maybe
yeah.
then you need to reassess whether that tourniquet is necessary, or can, their care be, can their hemorrhage be controlled with direct pressure or some other reason or other cause? Sure, but for 99% of us out there who are going to be transporting to a hospital, there's no reason to take the tourniquet down.
I wanted to kind of jump into the differences between the hemostatic agents, but before we do, any easy way to remember what devices to deploy based on
The injuries.
where the injury has occurred on the patient?
Yeah. So
Because
yeah.
I probably shouldn't be packing in some places.
No,
And
so,
I should be tourniqueting some and not others.
So what we teach is junction limbs. Pack the junctions. Pack the junctions. Show armpits, groin,
Sure.
base of neck, not like upper, and seal the box. Seal is like the torso all the way down. Chest injuries, diaphragm,
Including belly?
So, like, we try to hit home about doing the belly if there's like an evisceration. Obviously, we're not going to put a chest seal on there, but if it's getting closer to the lungs and you're like, I don't know, it's not gonna. I'd rather have you guys do that than to get that, have an underlying injury of.
It's a big sticker.
Yeah.
It'll come off.
And they're not gonna be happy, but it's that's what we're teaching, like the LEO that are not really medically trained is, arms, legs, tourniquet, groin, armpits, base of neck. You can pack, and if anything is within where if you think is close to the lungs, just throw a chest seal on it. Like you said, we are very fortunate to be closer to the trauma centers, or we can use helicopters. They can reassess and deem necessary if it's there or not. But that's why we kind of give these guys the IFACs, and we teach them before we give them the medical equipment, because I'm not going to be giving someone that's not trained on this this stuff to use, because you can't hurt someone.
Sure.
But it's pretty easy to use those three things to help teach people that are not really in the medical field, and that, like I said, we use it on some hyper realistic trainers, but also and actors too. Yeah. So, did I say anything?
So tourniquet the limbs, pack the corners, and seal the box.
Yep.
All right, fair enough. Easy peasy. Over Tony's shoulder there is there's a chest.
Oh, same chest seal.
There is a chest seal, yeah, and there is more than one variety. How does I say that tongue in cheek?
Yes.
Advantages and disadvantages. What separates some from others? Hyphens versus SAMs versus.
So some have a
A
valve.
defib pad.
Yeah, defib pads. So at my department, we run the hyphen vent, twin pack, right? So forward thinking, I have an entrance wound, I have an exit wound. They're already vented. Yeah, you could still have to burp that, but it's designed so that you don't have to. They'll actually even tell you could cut up the package and then utilize that, tape it on 3 sides to make more.
Mm-hmm.
Same process of, hey, if I didn't have a commercialized device, I could use AED pads or the even the wrapper that it's coming in too, just to multiply this. But commercialized devices are very cheap. Like Joe said, we want to be very aggressive, put it on early. We're trying to prevent that tension pneumothorax, right? We're trying to prevent having to do needle decompression. And then some have valves on them, so that this is a SAM. It has a valve on it, and
So obviously it's a one-way valve, so that air escapes from the chest and doesn't come back in, right? Because
Yes.
we don't want tension to build up.
So it's a variation of it. Some providers like this because it's a hard plastic valve. So during movement, or let's say you put this on your back, a patient's back, you got to drag them, then that one-way valve is protected. Whereas some people worry about if it's just one flat sticker, if you will, then are we going to be able to collapse those vents so we're not allowing that air to escape but not come back in? So there's that whole debate, but I don't know. Commercialized devices, it's got to be a must. I don't think making these in the heat of the moment is a good idea. These are, I mean, I think you can get a pack of twin hyphens for like $12 or $14. Like this is a cheap product to purchase. It just depends on provider opinion whether you want the one-way hard plastic valve sticking up, or do you want more of a slim profile with the hyphen vent. Those are just the popular ones. I know there's other brands.
Yeah.
There's Ashman with it looks like a
Hey,
big
yeah.
whoopee cushion
Yeah.
coming off of it.
Those
you
are
know,
like
so-
those are like not existent anymore. Those valves on those things never really worked. Yeah, there's Halo. I think Halo's still out there.
Yep, Halo's.
Sam's cool. I like the rigidity. That's what we carry at our fire department and a lot of our teams. But the North American Rescue hyphen works well. The only thing is if you have it on the back, it's just little channels, and that can be occluded extremely quick.
Sure.
So, but you can fold them. You can have multiple in there. That one comes with one, and it's a giant pack. Hyphen has an entrance and exit wound, and you can fold it in half and throw it in a kit or something like that. Yeah.
Come up with
Yeah. So I mean,
cover two bases,
there's pros
yeah.
and cons. I mean, like tourniquets, there's so many out there. There's recommendation by the Committee of Tech, TECC, and we kind of hit on that in our classes that some of them might look cool, but they don't work. Or the rats is like is like the number one thing. Is have you ever seen a rat's tourniquet? It's like that. Looks like a bungee cord.
It's a bungee cord.
Yeah.
Or they're just a piece
I'll
of-
cut that up in
yeah.
front of you if you bring that to one of our classes. Yeah.
And what's the other one? The SWAT, which is
SWAT T.
SWAT
Yeah,
T.
so those are. It's not recommended, but we can talk about tourniquets for 3 hours in here, but there's That's not a recommended, but it works good with like kids and canines because it's different anatomy. But yeah, just there's so many out there. If you have any questions, you can either call UH and they'll shoot it over to one of our guys, or you can go online and just look for recommended tourniquets, and they do it every year. They do a lot of tests, so there's a lot of stuff out there, and we just want to make sure that we're giving our providers some high-end equipment.
So the thing that I remember being taught early in my career, and then it just fell off the face of the earth, like never to be talked about again, was wound packing. And then all of a sudden we're back to wound packing.
Oh yeah.
Right? It's like, that's for nurses only in the hospital and stuff. And then all of a sudden we're back to
Yeah.
wound packing. What's the general technique for those who may not be familiar or have had it ignored for a period of time in their career, and now we're back to it? Do we need a specific gauze product? Will anything do? And who are the candidates?
So as far as packing wound, just based on the concept is that we're trying to fill the space, right? If you're bleeding into an empty space, your blood is going to keep bleeding until you fill up that space. So we're trying to take up the space by putting packing in there. If you pack that wound, you fill up the space, then there's back pressure that ends up being applied to the bleeding area, and by you're putting pressure on that bleeding area to stop the bleeding. So that's the concept of why we pack wounds, because we're just trying to fill up the space so that there's not space to bleed into. So the important thing is really starting deep into the packing. If you can think of a hole, there's a deep part of the hole. You don't want to just close the top of the hole. You want to really get things deep as you can into the hole. So most people teach a technique where you hold the packing in one hand and you have your finger in the other hand, and you sort of keep pulling it out, pushing it in, and kind of pulling it, pushing it in, pulling it, pushing it in. So that's sort of the technique that is often taught to fill up the space. Now you want to fill up the space with gauze, that's great. And now we have, bleeding control gauze. So now we're taking gauze, we're impregnating it with a chemical that also helps to stop bleeding. So it's like good and better, right? So we're adding another piece to it. So that's the concept behind, quick clot and other kinds of, bleeding gauze, or gauze that has medicine impregnated into it to help stop bleeding.
Where should we not pack? We just put packing wherever we want, right?
I mean, hey, if it's bleeding, you got to stop the bleeding, right? Yeah, so, Joe talked about high in the neck. You don't want to pack. People have, there's some controversy, or I think a little bit of controversy as far as abdominal
belly,
wounds
right.
go, like should you pack bellies or not. And so that's a controversial area. I don't know if we want to get into that either.
No, not really. But
So
we can
there's
leave it exactly that.
Yeah,
It's
but
controversial.
there's some controversy involved in that.
No go on the thorax.
I would not pack the thorax.
Yeah, okay,
Yeah,
so that's,
for sure. No.
That was really the point I want to get made there. Is
Yeah, of course.
it's one thing if you're packing close to the thorax. It's another thing if you're packing it directly through the chest wall.
Exactly. Chest seals. I mean, all those sort of things. We really are better for the chest for sure.